$5 trillion per year on healthcare. This calculates out to 13,000 bucks per person per year, compared to numbers like $8,000 per person in Germany, 6,000 in Canada, and 5,000 in the UK. Okay, so the UK maybe spends a little bit too little because the service is so bad, but you get the idea. We're spending a lot of money and way more than other developed countries. I'm not making this up. This data is from the OECD. According to US data, our health expenditures account for 18% of the economy, heading towards 20% in another 8 years. Using the OECD measures, our 17% compares with like 12% Germany, 11% Canada, 10% in the UK. By the way, 10% of our people have no health insurance at all. All the other developed countries in the world have virtually 100% of the population covered. Professor Pete, help us out here. The election's coming. We're going to hear different proposals on healthcare. What should we do? And what can we show for all this spending?
Not much better health, Phil. We don't do so well. Admittedly, we spend, a king's ransom on health expenditures in the United States. Yet, when we look at population health numbers, they don't look so good compared to other developed countries of the world. Our life expectancy at birth is poor. Our infant mortality rate is poor. Now, not all of these things can be laid at the doorstep of the healthcare system, but certainly that's part of it. Take life expectancy at birth. According to the World Bank, Americans have life expectancy of about 77 years, with women having somewhat longer life expectancy and men less. There's about a 5 or 6 year difference in life expectancy at birth between men and women. But take that life expectancy of 77 years and compare that to, say, Germany, Canada, and the UK that have life expectancy respectively of 81 and 82 years. In Japan, it's even greater. Life expectancy is 84. So the US does not compare favorably to these countries in spite of the huge amounts of money that we spend. Now, if you want to look at it a little bit differently, we could just look at life expectancy at age 65. Because as I'd mentioned, the US has relatively poor infant mortality. So some of the impact on life expectancy at birth is driven by high infant mortality in the United States. All right, so let's strip that out. Let's just look at life expectancy at age 65. Well, according to the OECD, that's the Organization for Economic Cooperation and Development, in the US, we can expect to live another 19.7 years once you hit 65. It is greater for women, a little less for men. But these numbers, again, do not compare favorably with other countries. Germany is 19.9, the UK is 20, Canada is 20.9, and Japan is 22.2. And I should point out that virtually everyone who's 65 or older in the United States also has public health insurance, much like they do in Europe or Japan. The public health insurance I'm referring to here is Medicare. There are other factors, I want to reiterate, that impact life expectancy: levels of education, levels of sanitation, environmental quality, crime levels. All of these things play a role in how much the healthcare system should be blamed for that. Is maybe the topic of a different podcast. But clearly, medical care is important.
So it sounds like those numbers you're talking about are dealing with averages and median, something like that. What about the equity factor? Since I'm one of the 90% who have coverage and I'm white, relatively educated and affluent, shouldn't I fare a little better than these statistics you're talking about?
Well, yeah, Phil, there are big health disparities in the United States. As I mentioned, some of it is between men and women, with women living considerably longer than men. But some of it is also by class and income. The well-off can expect to live an additional 10 or 15 years compared to poorer people. Some of this is due to medical access or access to medical care. Some of it is due to better and safer environments. Um, some of it is due to better levels of education and health behaviors. And there are other, at least we believe that there are other reasons that we don't fully understand that partly underlie these huge disparities.
This sounds like a bad deal to me. Something seems amiss. What's the deal here now? Our listeners understand that much of the problem is the cost. What's the source of this cost? Is it apparently misallocation of resources, or what's going on with the costs?
Yes, well, the politicians often put most of their emphasis on access and utilization and uh, seeking to get a greater and greater share of the population insured, and all of that I think is worthy, and most people support that. But when you ask typical Americans what's the worst part about the American healthcare system, they'll tell you it costs too much, plain and simple. Now, why does it cost too much? Turns out that it's not really utilization. It's not that Americans uh, go to the hospital more or stay in the hospital longer. In fact, on the contrary, our hospital length of stays tend to be relatively low. We don't go to the doctor more often than others around the world, and nor do we consume more medications than others around the world. The difference is the price we pay for those things. So really a matter of high prices as opposed to high levels of utilization. Why do we pay such high prices? Well, one sort of obvious point to make here is that, at least for much of healthcare, people are insured. Most people have health insurance, and most people are covered for most things. So, quite simply, when somebody else is paying the bill, we all are heroes in wanting the best that money can buy when it comes to health services. So this tendency to be, absolutely heroic and spare no expense for healthcare has led to not just high levels of spending at any given point in time, but a system that encourages technical innovation that generates, expensive new procedures and services that will be paid for. So the competition over time has not been about getting price down, as it might be in many other sectors of the economy where there's competition. Rather, the competition is about finding new products and services that you can charge ever more for. And in many cases, the incremental improvement in health afforded by these new technologies is pretty marginal. Some are breakthrough new technologies that really are very useful, but many are really quite marginal. And so that helps explain why we spend so much with little to show for it in terms of health. Now, there's other factors. Lack of competition. Most hospital markets are pretty concentrated, or if not outright monopolistic. Not that many people travel the world for hospitals. In fact, many people don't even travel their state for hospitals. They just stay within their community. And of course, there's lack of competition in many physician service markets and in pharmaceuticals. Patents confer monopoly power on producers, and there's a monopoly power amongst insurers, and we could go on. There's a big problem with the monopoly. Oh yeah, one point I should emphasize though, besides patents, another form of government sanctioning of monopoly power is licensure. The government licenses many, or really most, healthcare occupations. And while the professions will argue this is to protect the quality of care that people receive, many economists see it really as just a mechanism to keep supply down and incomes up. Anyways, to sum things up, a noted health economist, Huey Reinhardt, who used to be at Princeton, uh, said it quite simply: "It's the prices, stupid. That is why healthcare costs so much." And getting a grip on prices in the United States is really the key item on the agenda. Having again, let me just reiterate that for all the money we spend, our quality of care is not exemplary. We talked about life expectancy and infant mortality at more of a micro level. We can look at things like hospital infection rates, which do not compare well with many other countries of the world. Quality of care in other countries can be quite good, not to mention just lower cost. I remember one time my wife and I were in China, and she got an eye exam for 65 cents,
Mhm.
and her prescription was fine. I know people who go to Mexico for dental care, for expensive dental care, and it's just fine and a whole lot cheaper than it is here. So the industry of medical tourism has been doing quite well recently as people afford themselves the lower prices and good quality that's available in other parts of the world.
We're Americans, Pete. There must be something good about our healthcare system.
Well, there is a survey by the World Health Organization some years ago that ranked health systems of the world did give the United States very high marks for new technologies and responsiveness. If you have the money, you can get some fantastic care in the United States. So yes, we are an engine of technological innovation in the world, and that's not to say that other countries don't make important contributions. They certainly do, but we really are a leader. American healthcare is to some extent, well, yes, there's a lot of great innovation. I think you can also be critical of it as being not as responsive to consumer demand as it could be. I might point out that I think it's easier to get a cheeseburger at 3 a.m. than it is to get, medical care. A lot of the institutions in the healthcare system really are designed to serve the healthcare industry itself. They have had unique power and protection from competitive forces through a variety of mechanisms. Licensure is one of them. There's corporate practice of medicine laws that prevent businesses from really getting involved in making a lot of decisions about healthcare. And these things have kept healthcare something of an oasis from competition, both internally and externally, so that lives can be, very comfortable for providers in the healthcare industry. Sir John Hicks, a Nobel Prize winning economist, famously quipped that the greatest monopoly profit is a quiet life. And to some extent,
Hmm.
a lot of healthcare providers have nice, comfortable lives, high incomes. And I would point out, as somebody who's been an academic for decades, students clamor to get into the medical professions like medicine or nursing or pharmacy or dentistry. Why? They might tell you they want to help people, but I suggest it has a lot to do with the high incomes that are afforded in those occupations. If the incomes went down, I think applications to those grad programs would and college programs would too.
A few of our listeners may not be aware that you recently published a book on this subject, Professor Pete. Reading the books definitely helped me understand the structure of the industry, including the pricing mechanisms, even if the book was a bit academic. But tell us about the book.
Sure, Phil. Yeah, I did write a book, and I'd have to say with some help from a few people. I appreciate your input, Phil, as well as a friend of mine, Alan Bennett in Virginia, and the great editorial support I got from Jim Hill in Iowa. But the book, it's not a textbook, although publishers wanted me to do a textbook, but I wanted to write something easier to understand, shorter, and the idea was to make this accessible to just about anybody. Anyways, it has three parts. The first part provides sort of a historical explanation of how healthcare technologies and institutions evolved from the earliest times. And then the second part of the book, second section, kind of deals with some traditional topics in health economics, such as health insurance, such as monopoly power, occupational licensure. And we also get into this issue, what economists call allocative efficiency. How do you determine when something costs too much? That's a big problem that we have in healthcare. Ordinarily, you decide if something isn't worth the price when you go to the store, when you shop online. In healthcare, since someone else is paying the bill, we depend on other institutions, insurers, public or private, to make these calls. But many would argue that they don't do so very efficiently. So there's a chapter dealing with that issue of what we call allocative efficiency. And then finally, the last section of the book deals with the relationship between the health sector and the economy as a whole. To what extent does the healthcare sector fuel our economic growth, and to what extent does it hinder it? What are its impacts on productivity? What are the impacts on income distribution, wealth distribution? Some of these larger macroeconomic issues are taken up in the final part of the book.
One, does your book have a name? And two, how's it done so far?
The book is entitled American Healthcare: Why It Costs So Much Yet Remains a Beacon of Growth and Development. Well, I'd have to say it's not flying off the shelves, but my mom read it. Eventually, I got my wife to read it.
Nice.
It is actually quite a few academic libraries have it, and really some quite good ones hold it. In these days, a lot of library holdings are in electronic form, so not very many have this book, or frankly any book anymore that's hardcover. But there are a lot of academic libraries that have it. It's out there, and I know it's been used in the classroom in a few places.
Mm-hmm.
So
Okay. Well, let's focus on our headline issue here, healthcare costs. Tell us more about why U.S. healthcare costs so much.
okay, well, let's come back to it again. I remember I quoted Huey Reinhardt, who said it's the price is stupid. So we do need to focus on that. There have not been sufficient forces in the health sector to discipline prices. I mean, the first point is sort of the obvious one that I've made, and that is that when you're insured, you don't care too much about the cost or the price. I mean, you might recognize that costs are extraordinarily high in the U.S., but when it comes to your own behavior, since somebody else is paying the bill, you're going to go all out. Sometimes we call that moral hazard. Just imagine you're on a business trip and you have an expense account. How many people are going to stay at Motel 6 and eat at McDonald's? Most people are going to go for something a little better than that if their budget allows. So for these reasons, consumers don't want to economize, and the providers have no incentive. They like the idea of making money. So to some extent, it's been up to the insurers to call the shots about what's not worth paying, and they have done a pretty lousy job of doing that. First of all, they in the United States, unlike many other countries of the world, we will not embrace cost effectiveness analysis for resource allocations. Medicare, in particular, shuns it, and to some extent, Medicare is kind of I don't know, the gold standard for coverage decisions. If Medicare covers something, then the private insurers usually assume that they have to cover it too. So we have a problem that we don't have price competition, that consumers are insulated from prices, the lack of cost benefit analysis. But then let's also go to the issue of monopoly power. And at the first instance, we can refer to just the high concentration that exists, say, in regional markets amongst hospitals and medical specialists. But nationally, you might find concentration in the production of various medical devices. But more broadly, when economists speak of the idea of monopoly, it really does include the notion of lack of substitutability. In a perfectly competitive market, if you took an econ class in college, you might talk about the market for corn. I lived in Iowa for years, and arguably one farmer's corn is like another farmer's corn. It's very substitutable. But in healthcare, there's tremendous differentiation out there. Every drug company tries to make a case that their product is different and better than the other guys. Providers, hospitals, they all try to establish their niche as being higher quality than everybody else. And so this lack of sort of perfect substitution undermines shopping and competition. It's compounded by government support for monopoly power. Patents on drugs or medical devices would be one. Many would say we need serious patent reform to unlock price competition. Then there's the licensure issue. There was a big study done by the Obama White House that concluded it was a major problem in healthcare, and calls for they have made major calls and have been lobbying the states, which really tend to regulate this licensure, to loosen up. Many of the states are, reluctant to do it because they're influenced by the industry that likes to keep things just the way they are. They like making lots of money.
So then how do these high costs impact the economy overall?
Clearly, from a global standpoint, we allocate too much to the health sector relative to other countries of the world, particularly when you look at how little we get in terms of improved health relative to other countries. So, sort of putting at on the dinner table so you can easily understand it. If American healthcare was more efficient, your wages or salaries would be higher. There would be more money in your pocket if we had a more efficient healthcare sector. As it is, health insurance premium for a family of four is, I don't know, must be 25, 26, $27,000 now. It's really high. Now, employers cover much of this, and if your employer doesn't, Obamacare has provided options with Medicaid expansion or with the exchanges. So a lot of people don't feel it. It has maybe made things more affordable. But one of the problems with the Affordable Care Act is it really has not brought costs down. And so it did get a lot more people insured, but its impact on healthcare costs has been somewhat muted.
We're starting to understand what the problems are now and why the costs are so high. When we kind of accused your book of being academic, I don't really mean it's hard to read. Pretty readable book and understandable, but it's academic in the fact that it's all about the market structures and the pricing mechanism, and not about recommendations. And what should we do about this? You ready to go today, Pete, and tell us what we should do about this?
Sure, I'll stick my neck out. Usually gets chopped off when I do that, but I'll do it again anyway. Yeah, in the classroom, at least I've always had the position that I don't want to be too prescriptive. I like students to draw their own conclusions, but this is a little different here. So yes, what should be done? It should be obvious when you look around the world that other countries that have some variant of a single payer seem to be doing better, both in terms of lower costs and equal or better health outcomes. Now, when I say single payer, that doesn't necessarily mean that we just have one insurer. It might mean a coordinated network of payers that are overseen by government agencies, where prices are determined with government oversight, and the prices might be pretty much homogeneous. Now, sometimes the systems we see, like in Canada, it's really not a national system. In Canada, each province really has their own system of healthcare reimbursement for doctors and hospitals. In Germany, they have a system of occupational related health insurance, and there's some movement. You can move from one insurer to another. They call them sickness funds. This goes all the way back to the time of Bismarck in the 19th century. Anyways, those systems seem to work pretty well. Governments can be involved in keeping a lid on prices, but particularly in places like Germany or Holland or Switzerland, consumers do have choices in which insurer they use. And in some places like Germany or even the UK, by the way, in the UK, not only does government pay for healthcare, but the government provides most of it. So most everyone who works in healthcare works for the National Health Service. They're government employees. I don't think there's much appetite for that sort of thing in the U.S. That is a National Health Service. But we have been inching towards a bigger role for government when it comes to payment. The expansions in Obamacare would certainly be a significant lurch in that direction that occurred, some years back now. Anyways, I guess the point I'm trying to make here is that some sort of consolidation of payment with public sector oversight on prices is important. Associated with that, I believe, is use of cost effectiveness analysis. And countries like Germany or Canada or the UK, they embrace this pretty readily. the UK has an organization called NICE, National Institute for Clinical Excellence, and they make lots and lots of recommendations about what's cost effective and what's not. And those recommendations are usually adhered to throughout the healthcare systems in the UK. I think that that's probably the number one issue is to probably get more consolidation in payment. I wouldn't necessarily say it has to be Medicare for all. One of the concerns about Medicare for all is that it could evolve to be Medicaid for all, with with excessively low levels of reimbursement, which would be which could do great damage to the healthcare system. I think that as a country, and as a population, we need to embrace the notion of economic efficiency in healthcare. To argue that some things cost too much in health is not unethical. In fact, it is ethical. I've lectured in medical school classes about this, and people in medicine often reject that idea. That to them, anything you can possibly do to help the patient is ethical. The idea that you cut it off because of cost, they think is unethical. Well, I beg to differ on that. I think it's very ethical, and we need to embrace that ethic. Now, I might point out that if we do have if we do move towards a government system, and one way that would have accelerated that, I think, was in the Obamacare deliberations. It was talked about having a public sector option. My guess is it would have been pretty popular, and it would have over time squeezed out a lot of the private insurers. I think this is why opponents, fought it so strongly. They just felt that it probably would, and that would damage their economic welfare. But it would not totally eliminate private health insurance. In countries like Germany, if your income is high enough, you are permitted to go outside of the sickness funds and get commercial health insurance. The UK has private health insurance too. In Canada, like I said, you're insured for doctors and hospitals, but other areas, dental care, for example, pharmaceuticals, that's often private health insurance. I do think we need occupational licensure reform. I think that much of the licensure regulations we have serve the providers a lot more than the public. So this needs to be looked at. And to reiterate, much of this occurs at the state level. So the reform has to be driven at the state level. But the federal government could put a lot more pressure on the states about this than they are now. I would say the federal government should up its game in strong arming the state capitals. We need more competition. One interesting thing that I've observed, I've taught in medical schools, allopathic, osteopathic medical schools, but it's interesting to see the rise of the osteopathic medical schools in the US. They used to account for maybe 5% first-year medical students back when we were in high school. Now it's about 1 out of every 4 medical students is in a DO program, not an MD program. And how did this happen? The osteopathic medical schools are very tuition driven. It's the result of market forces. And so I think we need to see more of that. Now, we do have the advent of these high deductible insurance plans, which I think have been very helpful. They came about with George W. Bush's Medicare Modernization Act. And many economists think they've actually been quite effective. A large portion of the population now has a high deductible insurance plan. Might be $5,000. There's a lot of variation there, but there's a significant deductible, and anything under that deductible, well, you're incentivized to shop. And I think that has been working to some extent, but it's impeded by lack of access to information, particularly price information. But consumers need to take the bull by the horns to a greater extent and be more willing to exercise their consumer sovereignty and make decisions on their own, or at least in collaboration with their providers. Anyways, those are at least some ideas. Oh, here's another one too: a patent reform. Some people have said instead of patents to incentivize new technology, why don't we give out more gifts and grants to researchers in universities and elsewhere? Prizes is another idea. If you come up with a really good idea and a good product, you can get a really hefty prize. Some of the money that's kept, that's earned, that's the right word, in the current system as a result of patents is exorbitant. Many economists think excessive. You can still generate a lot of technological innovation, maybe more, by reallocating resources to different systems of incentivization.
That's fantastic, Pete. It's nice to see the recommendations laid out. You think these recommendations could bring our costs down to the equivalent of the other countries that we've talked about in the beginning?
Yeah, I do believe that. I don't think anything would happen overnight, and I think our system is very resistant to change. But I think over time it does change, and it will change. What's not sustainable won't be sustained, plain and simple.
Yeah.
We will eventually move towards a more efficient healthcare system, and I think there's great potential in new technologies. So the combination of new technologies, telemedicine has been very helpful. New drugs, new medical procedures, the use of artificial intelligence, all of these technologies and many more, I think can be very helpful, but it also has to be combined with economic and institutional reform to generate more competition where possible. And we need to rely on more government oversight where necessary. So you put all those things together, and I think there's great potential for a more efficient health sector that not only doesn't hurt us so much in the wallet, but as the title of my book says, remains a beacon of economic growth and development for decades to come.
Okay, fantastic. Now we're looking forward to the next edition of the next book, Pete.
Yeah, well, I have some ideas. The next project.
Okay, so we went a little long today. As a special treat for those listeners who put up with this whole 31 minutes of healthcare, we're going to go out with a special rendition from the Norman Sylvester Band, Healing the Healthcare Blues.